Hello everyone, I'm Dr. Lahari here, and the topic for discussion today is management of medically compromised patients and oral manifestations. The learning outcomes at the end of the topic, you should be able to identify oral manifestations and detect the oral manifestations of common medical conditions. This is what I have picked out amongst the entire the learning outcomes that have been listed out here. And this topic is specifically only dealing with the oral manifestations, since the rest of it has been already covered in the previous lectures that were uploaded. When you talk about relationship of the oral cavity and general health, it is really important because number one, abnormal oral findings could represent an oral manifestation of systemic disease. For example, if you are looking at a patient with enlarged gingiva, you could actually be looking at leukemic gingivitis. History taking and other information, example like lab records, physician records, help determine the extent to which the patient's medical status allows them to tolerate stressful dental treatment. For example, a patient with unstable angina. You would want to know the medical records of the patient before you determine how long a procedure you could plan or how well the patient would tolerate it. Lastly, patients' dental status directly or indirectly affects their medical status. For example, and this is very true for edentulism, which leads to poor nutrition, especially in the elderly. And periodontal disease has been proposed as a risk factor for vascular diseases as well as for diabetes. The reasons for taking medical history in a dental setting is number one, again, health problems might alter dental management of the patient. For example, if you're in a situation where a patient is aware of the medical problem, like diabetes, you would want to specifically alter management of the patient. Situation number two, patient may not be aware of the systemic condition that he could be manifesting signs and symptoms of HIV, where you are the dentist. You as a dentist are the first one to probably help in diagnosis. Or you could be in a situation three where this patient is aware of a medical condition but may not want to disclose. For example, if the situation is related to drug abuse. There are more further reasons for taking medical history in a more detailed manner. Number two, which is medical disorders can result in emergencies in the dental office. If you, for example, have a diabetic patient who's experiencing a hypoglycemic episode, it becomes a medical emergency and it's important to deal the patient carefully. A cardiovascular system patient experiencing angina during stressful dental appointment would also be a medical emergency. Thirdly, certain patients need medications before invasive dental procedures. For example, if you're talking about patients who are risk of infective endocarditis, and they may be recommended an antibiotic prophylaxis before certain dental procedures are started, especially invasive dental procedures. Keeping this in mind, let us look at some problem-oriented approach to identify systemic diseases. These are some case examples which I have picked up, and I thought it is important that we go through these case studies. A 25-year-old non-English speaking Vietnamese man presented alone to the dental clinic with the chief complaint of non-healing bilateral ulcers on his tongue since 2 weeks. He had moved recently to Malaysia from Vietnam with his girlfriend. He denied any medical problems, medication, or history of trauma, cough, smoking, or alcohol abuse. Looking at the clinical picture, bilateral ulcer, irregular in shape, the differential diagnosis list could include anywhere from oral squamous cell carcinoma to a traumatic ulcer to a tuberculous ulcer or an ulcer due to STIs like syphilis. But all of these were considered unlikely given the medical history obtained through a translator. On the next visit to the dental clinic 5 days later, the patient's girlfriend revealed that he had a long history of grand mal seizures. She stated that he refused to take his medication and had multiple seizures the past several weeks. Now, this explains the ulcers generally because bilaterally, because the patient would have bit his tongue during an episode of the seizure. He believed that epilepsy was a psychiatric illness and his cultural background prevented him from admitting to a psychological problem. This case reveals the importance of persistence with medical history to identify a systemic problem that is manifesting in the oral cavity. Let us look at another case. A 41-year-old woman presented to the dental clinic with an asymptomatic swelling of the right lower side of the face for the past 5 days. She was on a holiday visit to Penang from Melbourne. She was not being followed for any medical problems and she denied taking any medication or any history of trauma or toothache. The extraoral appearance was highly suggestive of an odontogenic abscess, but there were no posterior teeth on the right side clinically or radiographically. Further history taking revealed that this swelling arose over a 1 to 2 hour period and that it has occurred once about 2 years earlier. The previous episode lasted about 7 to 10 days and disappeared in about a few hours. On further examination, a pulsatile sound could be heard through the face with a stethoscope. The patient was referred back to her physician in Melbourne and was subsequently found to have an arteriovenous malformation. This case demonstrates the importance of medical history and HOPI. If there had been teeth in the area, an odontogenic abscess would have been considered. If the swelling was incised, there would likely have been facial arterial bleeding as a result, with a disastrous outcome. So again, it's important what these two cases reveal is that it's important that you take consistent, persistent history. Medical history should be thoroughly taken and then correlate to the patient's existing dental condition and will also help with better treatment planning for your patient. Let us look at individual diseases. We start off with disease of the renal system and oral manifestation as a result. Oral manifestations due to impaired renal function and for patients who are on dialysis, it's important to understand that 90% of the cases have symptoms of uremia. Generally, uremic stomatitis is present. High concentration of urea in the saliva and its breakdown into ammonia happens. The blood urea nitrogen levels are generally greater than 150 milligrams per deciliter, with a normal range is only 8 to 18. And in case of renal failure is generally over 50 milligrams per deciliter. There's a general chemical burn that happens because of loss of tissue resistance and ability to withstand normal and traumatic influences. Uremic frost are white plaques of residual urea crystals on the oral mucosa and skin. Enlarged salivary glands could be seen, reduced salivary flow and dry mouth also could be seen, and brown tumors could be seen. Moving on, patient could also have low caries activity due to high salivary nitrogen, a metallic taste and urea odor of breath, enamel hypoplasia, brown staining, gingival inflammation, petechiae, ecchymosis and bleeding from the gingiva, poor wound healing, burning and tenderness of mucosa, glossitis, candidal infection, tooth mobility, metastatic soft tissue calcifications of arterial, which are present in the arterial and the oral cavity as well, malocclusion, and socket sclerosis due to lack of laminar dural resorption and deposition of sclerotic bone in extraction sockets. Uremic frost, these are some pictures that I've picked up from a case which show you white patches on the ventral surface of the tongue and the floor of the mouth, and also widespread patches on the buccal mucosa. And after the patient has actually received treatment and his uremic condition has reduced, you would see that there is considerable amount of healing that is seen. Poor oral hygiene is also a very important factor, like we discussed in the all of the manifestations that are seen. This is one particular case where you had gingival hyperplasia in this patient who was on dialysis, long-term dialysis. Brown tumors are nothing but areas that contain old hemorrhage and appear brown on clinical examination. These are giant cell lesions and they have similar histological appearance to central giant cell granuloma. or giant cell reparative granulomas. They are osteoclastic resorption of bone and replacement by vascular connective tissue that is happening in those areas, which gives rise to the color of the tumor. Radiographic manifestations of patients who are on long term renal dialysis would be related to renal osteodystrophy or secondary to hyperparathyroidism. This generally happens late in the course of the disease. There is bone demineralization, loss of bony trabeculae, loss of lamina dura, and a ground glass appearance, which you are seeing in this particular radiograph here. This is also another case of oral manifestations of chronic kidney disease, where you see mineral and bone disorder, and there's a larger defective tumor growth like appearance, radiolucent, mixed radiolucent radiopaque area, and which could also be a renal osteodystrophy. Oral manifestations of hypertensive patient. Let us look at this case study. A 56-year-old businessman had come for routine dental checkup, and he complained of excessive growth of his gums since few years. He has used many different toothbrushes, but it won't get better. History revealed that he was diagnosed hypertensive 4 years ago, and he has been on medication ever since. We're all aware that drug-induced gingival enlargement is common manifestations of certain antihypertensive drugs, especially the calcium channel blockers, and this could be an important manifestation of hypertensive patients which should be kept in mind. Diseases of the GI and oral manifestations, gastrointestinal diseases. Crohn's disease. It's an inflammatory disease of the small or the large intestine. The oral manifestations could be recurrent aphthous ulcers or a hallmark of Crohn's disease, which is called as pyostomatitis vegetans. This gives a cobblestone mucosal architecture. Minor salivary gland pathology may be present with granulomatous changes. There could be diffuse swelling of lips, face, inflammatory hyperplasia of oral mucosa, and glossitis. Pallor and angular cheilitis are also present. This is an image of cases of pyostomatitis vegetans. If you see the images at the bottom, ABC show the case when it is in an extreme severe condition, followed by during healing phase and in a completely healed phase. Liver diseases, the most common ones that we should be discussing is hepatitis. Jaundice is a manifestation where total serum bilirubin count goes beyond 3 milligrams per deciliter. The oral manifestations could be petechiae, ecchymosis, gingival crevicular hemorrhage, and thrombocytopenia. Adverse interactions with drugs in alcoholic hepatitis can be seen, and drug-induced hepatotoxicity. It's important to use alternatives to NSAIDs. Liver cirrhosis also manifests with vitamin deficiency, anemia, and yellow pigmentation. It's important to understand that they would be hemostatic defects leading to changes in most of the tests, that is liver function test, prothrombin time, international normalized ratio, or thromboplastin time. Hematological disorders, bleeding and clotting disorders, oral manifestations. First of all, let's look at one of the most commonest condition, that is anemia. Iron deficiency anemia could lead to anemic stomatitis. There is manifestations of anemia in the oral cavity, which are classically characterized by angular cheilitis, glossitis, that is due to atrophy of filiform and fungiform papillae, pale oral mucosa, they could be oral candidiasis, recurrent aphthostomatitis, erythematous mucositis, and general burning sensation of the mouth. A variation called Plummers-Vinson syndrome or Patterson-Kelly syndrome leads to sideropenic dysphagia, in which the person has difficulty swallowing due to iron deficiency anemia, upper esophageal webs or strictures. The reasons for oral manifestations in iron deficiency anemia could be because of impaired cellular immunity, deficient bacterial activity of polymorphonuclear leukocytes, inadequate antibody response, or even epithelial abnormalities. Let's look at this case study of a 77-year-old woman who presented with an insidious onset of fatigue and burning sensation of the tongue on swallowing. 6 years earlier, she had undergone a total gastrectomy for early gastric cancer, which was curative. On physical examination, she was pale and had a depapillated, smooth, shiny red tongue with some central fissuring, findings that were consistent with a beefy red tongue. The laboratory tests revealed that there was cytopenia. In specific, the important values that note here are hemoglobin level was low, as well as the vitamin B level, B12 level was considered low. So the patient received a diagnosis of megaloblastic anemia due to vitamin B12 deficiency. She was treated with intramuscular vitamin B12 and a complete recovery after approximately 5 months. Sickle cell anemia, the oral manifestations which is of importance are radiographic features like the step ladder tuberculation, enamel hypomineralization, and calcified canals. There is generally increased overjet and overbite, especially seen in growing children. Pallor of mucosa, delay in eruption of teeth, orofacial and dental pain with no obvious reasons, cortical thinning, and deteriorated bone tissue. This is an example or diagrammatic representation of how the sickle cells block blood flow, and there's abnormal hemoglobin, and because of which there is sickle cell anemia. Thalassemia also has kind of similar radiographic features. Generally, the teeth have spiky, sharp, short roots, especially seen during the developmental phases of in children. There could be taurodontism, attenuated lamina dura, enlarged bone marrow spaces, and thin cortex of the mandible. Craniofacial deformities like the chipmunk facies could be seen. Um, Narrow maxilla and mandibular arches, and growth retardation. There could be delayed dental development, increased caries, as well as oral health considerations that occur if hemoglobin levels fall below 10 grams per deciliter. This is an example of a case with chipmunk facies and the typical radiographic appearance of hair on end appearance where the dura appears in such a manner due to the presence of thalassemia. Leukemia, the clinical features could be fever, fatigue or malaise, weight loss, joint pains, anemia, mucosal bleeding, and petechiae. Oral manifestations specifically could be seen more commonly in acute anemias than chronic cases. Gingival hyperplasia, which is secondary to leukemic infiltration, is the first oral sign of acute leukemias. Chronic leukemias, however, could manifest with exfoliative cheilitis, herpes infection, candidiasis, or mucositis. This is a case study which of a 21-year-old female patient who reported to dental clinic with bleeding upon brushing, swollen gums, and also which do not look good when she smiles. Her friends have been complaining that she has a peculiar bad breath and sometimes there is bleeding from her gums without any reason. Medical history revealed that she's been experiencing on and off episodes of fever since the last 6 months. She gets tired very easily after work and feels like sleeping most of the time. This is the oral manifestation. You can see boggy gingiva, which is a typical classical manifestation of leukemic gingivitis. And if ignored and only scaling were done, we would be missing out the most important finding. And if cure is provided, if treatment is done on time, there would be complete remission and patient could lead a normal life. So, identification of a patient with bleeding disorders, it's important to take complete history, especially family history of bleeding, hemostatic abnormalities, if there is spontaneous gingival or mucosal bleeding, epistaxis, easy bleeding, prolonged bleeding from superficial cuts, and especially, of course, lab studies. Keeping this in mind, the oral manifestations of platelet deficiency, especially that is which is called as thrombocytopenia, could be petechiae or ecchymosis. There could be spontaneous gingival bleeding and enlargement. Brown stained teeth due to prolonged gingival bleeding, which leads to deposition of hemosiderin on the surface of the enamel. In hemophilia, there could be many episodes of oral bleeding. There could be hemarthrosis, especially in weight-bearing joints. Of course, it is rare in the TMJ. This is an example of a case of thrombocytopenia where you can see that there are large petechiae, I mean smaller petechiae as well as larger areas of bleeding which are called as ecchymosis. and it could be also it's important to treat the condition, and otherwise there could be excessive amount of bleeding if case history is not taken properly and an extraction is performed. We're coming to the end of this topic with oral manifestations of diabetes. The diagnostic criteria for diabetes mellitus, I just wanted to remind you, could be an HbA1c level which is greater than 6.5%, a fasting blood glucose which is greater than 7 millimoles per liter, or a 2-hour plasma glucose which is greater than 11.1 millimole per liter, or in patients with symptoms of hyperglycemia, a random plasma glucose which is greater than 11.1 millimoles per liter. The oral manifestations could be oral dysesthesias like burning mouth, altered wound healing, infections like acute pseudomembranous candidiasis, dentoalveolar abscesses, xerostomia, primarily due to the medication that the patient is put on, silenitis, bilateral salivary gland enlargements, high caries incidence due to increased glucose in gingival crevicular fluid, xerostomia, and dental plaque buildup, gingivitis and periodontitis due to poor glycemic control and progressive destructive periodontitis. So these are some oral manifestations where you can see that periodontitis. This image shows the first green dots where the initial level of bone was, and after the patient, due to poorly controlled diabetes, the bone loss, which is typically arc-shaped, seen due to periodontitis. The patient could also have fissured tongue and candidiasis and a high caries index. Or more oral manifestations could be the presence of multiple periapical or periodontal abscesses, extensive amount of bone loss in most of the teeth, furcation involvement, and also in conditions where implants, in cases where implants are present, the presence of peri-implantitis due to poor glycemic control, and hence there is excess amount of bone resorption. So, with this in mind, I come to the end of this topic, and I want you to go back with this important quote which says, "The mouth is the mirror of health." And truly enough, through this lecture, you have come to understand that it's important to keep oral manifestations of all systemic diseases in mind. And when any of these manifestations are present, it's important to get a thorough medical history as well as medical checkup of the patient done. So, thank you. If you do have any doubts, please feel free to contact me.